Okay, let's unpack this. Imagine a challenge faced by basically every healthcare system out there.
Hmm.
How do you keep medical costs from, well, skyrocketing while still making sure people get quality care? It's a huge balancing act. Today, we're taking a deep dive into China's pretty innovative approach to this exact problem. They brought in this new system called the Diagnosis Intervention Packet, or DIP, payment reform, and we'll be looking at the early impacts, specifically in Guangzhou, based on a recent study.
Yeah, what's really fascinating here is how these payment systems are actually meant to shape healthcare delivery. Traditionally it was often fee for service, pay for every little thing.
Right, more tests, more procedures, more money.
Exactly. But the push now, globally really, is towards these prospective payment systems, PPS. Think of it like bundled payments, a fixed fee for a patient's whole treatment episode, more or less, regardless of the itemized bill. The idea is to cut down on unnecessary stuff and boost efficiency.
And people might have heard of DRGs, diagnosis-related groups. That's a common kind of PPS.
That's right. China's actually explored DRGs for a while, but getting them rolled out everywhere faced some real hurdles, just the scale and diversity of the country.
Makes sense.
So that's where DIP comes in. It's their tailored version, very data-driven, designed specifically to link the services provided with payment using mountains of historical medical records.
And for you listening, this deep dive is going to give you insights into the real-world ripple effects of a big policy shift like this. Not just costs, but hospital operations, patient care quality.
And even how doctors and hospitals change their behavior. It's really a shortcut to understanding these complex health policy dynamics.
Okay, so let's zoom in on Guangzhou. Huge city. They rolled out this DIP reform January 1st, 2018. And what's key here, unlike some other pilots that just picked a few hospitals.
Yeah, so went all in.
Yeah, Guangzhou put it across all 361 designated medical institutions doing inpatient care. That makes it a really important case study for the policy's wider effects.
Absolutely. And the study we're looking at by Fang and Jiang, they analyzed data from 2012 right through to 2020. They compared Guangzhou to other regions that didn't implement DIP.
How do they compare them fairly?
They used a pretty sophisticated method, synthetic difference in difference, or SDID. It essentially lets you build a synthetic Guangzhou, like a statistical twin of the city, without the DIP reform based on data from the other regions.
Ah, okay, so you can really isolate the policy's impact.
Exactly. It gives you a much cleaner comparison to measure the causal effect.
And what exactly were they measuring? What were the key things they looked at?
Well, the big ones were per episode inpatient costs, obviously. Then average length of stay, how long patients are in the hospital, often called LOS, and critically, in-hospital mortality, IHM.
But they looked beyond just those patient outcomes, right?
They did. They also examined healthcare resource use. Things like hospital bed occupancy rates, the total number of discharges, and even outpatient visits, trying to see how the hospitals themselves were operating differently.
Okay, and you mentioned DIP is different from DRG in how it groups patients.
Yeah, that's a crucial difference. DRGs look at demographics, procedures, complexity. DIP is, let's say, more granular. It directly combines the main diagnosis and the main procedure codes.
So like diagnosis X plus procedure Y equals one specific group.
Precisely. Which leads to this huge number of groups, over 10,000. Each gets points based on typical resource use, and then the actual payment per point is set based on those points and the city's overall budget for this.
Wow, 10,000 groups. That level of specificity must create some unique incentives.
Definitely. And we'll see how that plays out and what they found.
Okay, so let's get to the findings. When they first looked at the big picture, the overall results, well, they were a bit surprising, weren't they? Especially if you think the main goal was cutting costs.
Indeed. It was quite counterintuitive. The study found that DIP payment reform actually significantly increased per episode in patient costs.
Increased by how much?
On average, across all the hospitals, costs went up by about 1575 Chinese yuan per episode. Even when they controlled for other factors, the increase was still strong, around 1470 yuan.
So a policy often framed as cost control leads to higher costs. That's definitely something to chew on. What about the other main metrics, length of stay and mortality, overall?
Well, overall, DIP didn't have much of a statistically significant effect on either average length of stay or in-hospital mortality. Guangzhou's average stay did drop slightly, from about 9.6 days to 9.4 days after DIP started.
Small drop.
Yeah, but when compared to the control regions, it wasn't a statistically significant change overall. Same story for in-hospital mortality, a tiny, non-significant decrease across the board in Guangzhou.
So costs are up, but length of stay and mortality are mostly flat overall. Why would that happen?
That's the million-dollar question, isn't it? It really suggests things are more complicated under the surface.
And this is where digging deeper into the data becomes so important. Because when the researchers broke things down by hospital type, well, the picture changed quite a bit and got, frankly, a bit concerning in places.
Absolutely. That's where the nuances really emerged. While public hospitals also saw that cost increase, around 1580 yuan or so, the most critical findings, the ones that really raise eyebrows, were in the private and the secondary hospitals.
Okay, tell us about that. What happened in the private and secondary hospitals specifically?
Well, this is quite stark. In private hospitals, the study found DIP was associated with a significant increase in in-hospital mortality. It went up by 0.33 percentage points.
A significant increase.
Mhm.
Wow. And secondary hospitals.
Same pattern there. In secondary hospitals, these are often your smaller, maybe community or district-level hospitals. IHM also significantly increased by 0.31 percentage points. The size of that negative impact was clearly larger in these specific hospital types.
Okay, that's a critical finding for you listening to grasp. While the overall mortality rate didn't shift much, there was this clear, statistically significant worsening of mortality outcomes, specifically within private and secondary hospitals after DIP came in.
Exactly. It flags a potential vulnerability or maybe an unintended consequence concentrated in certain parts of the system.
Which immediately makes you wonder, right? Were hospitals changing how they operated, how they treated patients under this new payment pressure?
The study looked right into that, using those resource utilization metrics we mentioned, and they found evidence of what they termed cost manipulation behaviors.
Like what?
Well, for instance, DIP led to a significant drop in outpatient visits, a big drop, thousands fewer per day overall. But at the same time, discharge volume, meaning the number of inpatient stays, that actually trended upwards. It increased by about 61 episodes per day just in private hospitals.
Okay, hold on. Fewer outpatient visits, but more inpatient discharges, especially in private hospitals. That sounds like patients being shifted.
That's certainly what it suggests. Providers might have been moving patients from perhaps less profitable outpatient care into the inpatient setting, where they'd get that bundled DIP payment.
Ah, the incentive structure.
Exactly. And the study also floats the possibility, and this aligns with the mortality findings, that maybe public hospitals were selecting the more straightforward, potentially more profitable patients under DIP.
And maybe transferring the really complex, high-cost, perhaps end-of-life patients towards the private hospitals.
It's a plausible explanation for seeing both discharge volume and mortality rise significantly in those private institutions simultaneously. A complex sorting effect.
And didn't the study also mention something about hospitals anticipating the change, these anticipatory effects?
Yes, that's another interesting wrinkle. The reform was announced in November 2017, but didn't kick in until January 2018, so hospitals had a little lead time.
Time to plan or react.
Right, and the data show that average length of stay actually increased a bit in 2018, that first year right after DIP started, before it started to decline in 2019.
So they might have initially kept patients longer.
It suggests that providers might have initially tried to maximize their revenue within a given DIP payment group by extending stays, perhaps while they figured out the new system before adapting their strategies later on, maybe under tighter scrutiny.
Fascinating. So let's try to pull this all together. What does this deep dive tell us? It seems the early days of DIP in Guangzhou didn't really slow down hospitalization cost growth.
In fact, it increased it overall.
Right. And it had these quite concerning impacts on mortality, specifically in private and secondary hospitals.
Yes, those findings on cost and quality are definitely mixed, even troubling in parts. But it's also important, I think, to consider the broader context, the longer-term goals.
How so?
Well, the study points out that a system like DIP requires this unified national medical insurance data infrastructure. Building that system is in itself a huge potential long-term benefit for China.
Ah, so standardizing data across the country.
Yes, exactly. Which could eventually help reduce healthcare disparities between regions just by creating consistent standards and making information more transparent. So the impact isn't solely about those immediate financial numbers, it's foundational.
That's a really important point for you to consider. Policy isn't just the immediate outcome, it's also the infrastructure it builds for the future.
Precisely. And the study really emphasizes that future reforms, wherever they happen, need to look beyond just cost control. They have to systematically bake in performance metrics, outcome data.
With more focus on patient outcomes, not just what's convenient or profitable for providers.
Yes, a much greater focus on patient-centric outcomes, which always brings up that fundamental challenge. How do you design policies that truly align everyone's incentives towards patient well-being, first and foremost, rather than just, financial gain? It's the ongoing puzzle.
It really is.
Yeah.
Ultimately, this research just offers such valuable insights into how complex health policy implementation is. It shows how reforms, even with good intentions, can have unexpected, sometimes negative consequences.
And it highlights the really intricate ways healthcare providers, quite rationally from their perspective, respond to changes in the rules and incentives.
So today, our deep dive into China's DIP payment reform in Guangzhou, it's shown us a really fascinating, complex picture. We saw how a system, likely intended partly for cost control, actually saw overall inpatient costs go up.
And crucially, how it seemed to affect patient mortality quite differently depending on whether care was in a public, a private, or a secondary hospital.
We also uncovered those strategic behaviors by providers, shifting patients between outpatient and inpatient settings, maybe anticipating the policy changes, all playing a big role in the final outcomes.
Demonstrating just how powerfully incentives can shape what actually happens on the ground in healthcare.
This deep dive is such a stark reminder that healthcare policy is never ever simple. It's this constant dynamic interplay between the grand plans drawn up by policymakers and the real-world responses, the human element. So next time you hear about a new healthcare reform, maybe in your own country, what factors will you be looking at beyond just the headline promise of saving money? Think about those potential ripple effects on quality, on fairness, on equity, and the subtle, powerful ways human behavior ends up shaping what really happens.